brings us here today, of course we're calling it Department of Health Training, but what brings us here today is we are preparing for the once every 3-year visit from the Department of Health. We want to be prepared. So we went out, with some of you, maybe in this room, I'm not sure, yeah, there's at least one of you we went out with in here, yeah, hi Rachel. So what we have come up with here that we want to present to you are things that we found. What we're calling areas of risk. We did well, I think, but there were certainly areas of opportunity where we could be at risk if we didn't take that opportunity. And then also areas of interest. And what we mean by that is when we were out in the field, you guys had questions for us as well as we had questions for you, and we wanted to share what our answers were. So we obviously went out into the home, did co-visits, and then after the visit was done, we would have a one-on-one interview with the patient or caregiver as appropriate, and we would have a one-on-one with you, the clinician, and these are the things we found. So we're going to go through this training. We are going to ask you guys, if you don't mind, to hold your questions to the end. We really feel like we'll probably answer maybe even all of your questions. If not, then we'll be happy to stay as long as needed to answer any questions we can for you. At the end, there'll be a test. There's 12 questions. We'll give you a few minutes at least to do it on your own, and then we're going to reconvene as a group and actually go through them to make sure not only did we do a test, but we gave you the proper or appropriate answers if you missed any. So with that being said, let's move on and we'll do our objectives.
Okay, since I have the first one, I'll talk about it. Understand your role and responsibility to perform a complete drug regimen review and the medication reconciliation in the home.
And identify items that belong in the clinical bag and how to use them correctly, as well as describe basic concepts of infection control, including the importance of universal precautions and hand hygiene.
We want to make sure we understand the importance of complying with HIPAA regulations, including how to safeguard protected health information, and we're also going to talk a brief bit about understanding the regulations regarding the patient's right to make a complaint.
Okay, so I get to start. So my job today, I guess I'm going to stand up today because we're videoing, but that's okay. I sit all day. My job today is to review the drug regimen review and medication reconciliation process in the home. So what I want to point out is that this is a condition of participation. And what's a condition of participation? It's the rules that we have to follow in order to get reimbursed for care that we provide any Medicare or Medicaid patient. So this is not something we at the VNA made up. We have to do this. It's a compliance issue. So the first screen we're going to start with, we're going to talk about what a drug regimen review is, okay? And this shouldn't be anything new. It's in the OASIS for those of you that have been doing the OASIS. It includes the med reconciliation and review of all the meds the patient is currently taking to identify possible potential clinically significant issues and try to prevent those issues. We're going to try to prevent med errors. Okay, what is a potential or actual clinically significant med issue? It's something that, in your opinion as the clinician, okay, warrants MD notification. So if you feel that it's important enough to call the MD, you have to identify that as a clinically significant medication issue. What's med reconciliation? Okay, it's creating the most accurate list of all the medications the patient is taking and comparing that list to the MD orders that we receive on the referral. All right, so we're going to go over these in a little bit more detail as we go forward. Okay, next slide.
Let's advance the slide.
Yeah, okay. So what are potential or clinically significant med issues? All right, here's a list. Okay, adverse reactions to meds such as a rash, nothing new. Ineffective drug therapy such as an analgesic that does not reduce pain. I think sometimes we don't always think about that. Side effects such as potential bleeding from an anticoagulant. Drug interactions such as a serious drug-to-drug interaction or drug-to-food and drug-disease interactions. Duplicate therapy, they're taking the generic and the brand name drug. Same thing, same dose, different name. Omissions, missing drugs from a prescribed regimen, or they don't have all the prescribed meds in the home, or they're refusing to take those meds. Okay, dosage errors, too high or too low, or there being non-adherence, either purposeful or accidental. Okay, so these are the kinds of things you need to be assessing for when you're in the home. So we're going to talk about medication reconciliation, which is part of the drug regimen review process. And the reason that we really need to focus on this is so that we're actually doing this and representing that in the patient record with our documentation. Okay? So first of all, we're going to verify and collect an accurate and complete list of all the medications the patient's currently taking. So we're going to verify what that patient's taking in the home. Then we're going to clarify any questions there might be about the dose, frequency, purpose, potential side effects, etc. And then we're going to reconcile any discrepancies or clinically significant med issues with the physician. So we'll go into each one a little bit more in detail. Okay, so verify. So this is the one where we collect an accurate list of all the medications the patient's currently taking. And that includes all of these, the prescriptions, the over-the-counters, the culturally based remedies, herbals, dietary supplements, and vitamins. Okay, these are all the medications we're going to include on the med list. Okay, so we're verifying what the patient's taking in the home. So the next step is to clarify. All right, we're going to clarify any questions there might be about the drug route, dose, or frequency, purpose of the drug, how to administer, side effects. We're going to clarify all of the above to get an accurate entry of that medication in the medical record in point care. In the clarify step, a key goal is to identify those serious drug-to-drug interactions, and you know that the medical record flags that for you. So when you get a drug-to-drug interaction, when you enter a med in point care, it tells you what that is and it gives you the level, 1 or 2. And we're also identifying those potential or clinically significant medication issues that we just went over on the other slide. Okay? And what is a drug-to-drug interaction? I'm preaching to the choir here, I think, but it's when two medications that the patient has have the potential to interact negatively with one another. Okay. So we've identified the meds, we've clarified doses and frequencies and etc. The next step is to reconcile those meds. Okay, here's where we have to work, I think, a little bit harder. We need to communicate with the physician all identified clinically significant med issues, the interactions, the discrepancies, and discuss any questions or concerns that we have. If the dose or frequency question, clinically significant med issues, etc., has been identified, it is your responsibility for ensuring that these are reported to the physician. Okay, that's best practice. It's to, again, ensure that we don't have med errors that could cause harm to our patients. Therapists, just as a reminder, you will document all of this in a therapy drug review coordination note so that the drug review nurse can make the appropriate follow-up. So you're not responsible for calling the physician for this part, but you are responsible for identifying all of the above issues in that therapy drug review coordination note. Okay? So what exactly is your role in the home? The first thing I'll talk about are those OASIS events. For each one of these events, you have to complete a complete drug regimen review and perform a med reconciliation as indicated. So at the sock and rock, you have a referral. You're going to compare what the patient's taking with what is ordered. And you know that referral medication lists are in the attachments. If there's more than one, try to use the one that's dated the most recently. Sometimes we get one from the coordinators and then we get an updated one right at or around discharge, so they could be a little bit different. For research, we're responsible to review the medications that the patient is taking and make sure that the med list in point care still matches that. If we're doing our job throughout the episode, whenever there's a change in the meds, we're putting a new order in, this should be really easy because that list should be right on, it should be accurate, okay? So then, if we identify any differences or clinically significant issues, drug interactions, etc., we have to reconcile those with the physician, which means we call the doctor, we either speak to a representative, leave a message, request a call back from the doctor with a response. But the key areas here are the document areas. First of all, we have to document that we did call the physician, so that's really important. Okay, you can do that in your stock rock or research summaries. The next step is to document that doctor's response if you don't get it at the time of the call, and any prescribed changes. Now, it's really important we document that on receipt so it's timely. And again, you can document that in your clinical summaries if it comes right away, or you can document it later on in a coordination note. Okay, then again, you have to update that med list if there are any changes by putting in the new order, so that med list is then corrected based on the physician direction. Okay, and again, therapists, the MD contact will be completed by the drug regimen review nurse. Okay, next slide. Okay. Now for drug-to-drug interactions, or for the interactions report that's generated in the tablet, this is an issue that we have to do some work on. If the interaction is identified as a level 1 interaction, the physician must be called. Okay, the physician notification is required. So when that occurs, you need to document that phone call to the physician, identifying what the med-to-med interaction was. You know, this one's interacting with this one, that it's a level 1. And I've given you some examples. Now you know when you get the interaction, that medication interaction coordination note auto-generates, so it gives you something to write on. You don't even have to pick it. So these are the kinds of things we want to see written in that coordination note. If at the time of that occurrence you've called the doctor, maybe right from the home. Telephone call to Dr. Smith, spoke with Mary RN, notified of above level 1 interactions, request review by MD, and return telephone call for instruction. If you get that instruction right on the phone there, well, let me look, let me take a look at the chart, this is what the response is, you're good. Spoke with Dr. Costello, notified of above level 1 interactions, MD aware, and no change in medications prescribed. That's the kind of documentation we need to see to support that that has been done. The not okay ones are actual examples that I pulled out of charts over the last several months. No change in regimen has been made since the hospital. That doesn't cover us for notifying the MD in the community of the level 1 interaction, and he may not even know, because different doctors prescribe different drugs to patients. It's not always the same physician. MD notified, MD aware, we can't assume that if it's not documented that you've done that. Nexium is needed, pharmacy aware. The pharmacy's not signing our orders, so we have to be careful with that. PCP aware. So again, there's a lot of this that exists in our records right now that we need to make sure we're doing a little bit better job of documenting it accurately. So you're going to document the MD response to the level 1 interaction upon receipt. If the MD prescribes changes again, you're going to have to put in a new order to correct any medications, whether it's discharging it, different dose, or whatever. And just as an aside, within the last few months, the OASIS team, when your start of care or resumption of care comes into workflow, the very first step in that is done every morning by usually Chris or Brittany, because they're in the earliest, to push that through to the point where the schedulers can see it so they can schedule the visits. At that point, we are running the drug interaction report and faxing it to the physician, so they are getting copies of them. Okay? Next slide. Okay, now on each visit, we know that you're prompted to ask the patient, have there been any changes in your medication since the last visit? That's part of the care coordination section of the visit notes in point care. Okay, if there are any changes at that time, they say, yeah, the doctor said I can stop taking, this medication. Or, yeah, they said to cut that dose in half. Those are the kinds of things you have to call the doctor to verify and get a verbal order for. You can't just go by what the patient's telling you. You must get an order. Okay, if there changes a new prescription bottle in the home, you can put it in point care, because you've got a brand new prescription, doctor just ordered it, just picked it up in the home. You can put it in point care with a new order. You'll document on that instructions box on that med, verified with new prescription bottle in home, dated 9/12/19. Okay. If you've called the doctor and they get back to you, you're going to, again, document that response, confirmation of reported changes upon receipt. So there's like a circle. You identify, you call, you document the follow-up. Okay, and again, you'll update the med list with the MD verified orders by adding a new order. Okay, so that's it in a nutshell. I hope that was just a review for everybody and just reinforcing the importance of all that documentation to support what you're doing. Thanks.
Thanks very much. So on to the next portion, the infection control piece. So what is this? This is the list of everything that's in your clinical bag currently, as well as the asterisk items are for the therapy bags. So what do you have? You have an alcohol-based hand rub, alcohol wipes, BP cuff and Steph, a CPR pocket mask, disposable aprons, disposable bag barriers, gate, safety belt, a hazardous spill kit, a headlamp, liquid soap and bottle, lubricating jelly, mask with eye shield, non-sterile gloves, paper towels, pen light flashlight, Santa Claus, sharps container, we don't keep it in the bag itself, sterile gloves, sterile Q-tips, tape measure, and thermometer and tongue depressor. And then so the clinical bag itself has like 4 compartments. We're required to have a dirty pocket and a clean pocket. What's supposed to be in the dirty pocket? So it's really hand hygiene materials, soap, paper towels, alcohol-based hand rub, bag barrier, disposable apron, non-sterile gloves, alcohol wipes, and Santa Claus. And then in your clean pocket is basically your materials that you're using, your BP cuff, your Staph, tape measure, hazardous spill kit if necessary, CPR, pocket mask, trash bag, scissors, needle vac container, tourniquet. Additionally, if you have goniometers or nail filers, that would be in the clean pocket. So I always thought, why are the things that keep you clean in the dirty pocket? And the reason being is you need to have clean hands in order to access the clean pocket. So the thought is you want to clean yourself first and then get to your clean side where your materials are. So then going forward, how do you use the bag correctly? So everybody gets this on orientation, but we thought it'd be a good refresher just because DOH has a different set of eyes, different perspective than we as clinicians may. So what do? You want to place the bag on a clean, flat, dry surface. If you don't have access to that or you don't want to put it down, you can additionally hang it on a doorknob or the back of a chair. You want to wash your hands with soap and water or alcohol-based hand rub, 15-20 seconds if you're doing washing your hands, if you're using a hand rub until dry. And then remove clean supplies needed from your clean pocket and place on a barrier. You provide care. You never enter the clean area of bags until your hands are sanitized. So again, it's the clean side. And then also remember to completely close your zippered compartments until finished with the items, because the last thing you want to do is, from a HIPAA perspective, you have items that may be of privacy in your bag. You don't want those to be accessible to patients or their partners or whoever's in the house. You also don't want those items potentially being at risk for infection, whether it's due to a cat or something, or you slipping into there without washing appropriately. So, and then clean equipment. This includes your tablets and your cell phones. Remember, you might get a call during your visit, so if you're taking out your phone, you want to at least wipe it down before leaving the house. You don't want to wait until you're in your car. Just because the patient themselves, they're signing things on the tablet, you may be as well, so there's a lot of touching, a lot of transmission possibly on the tablet. So when you think clean your supplies, don't just think what you're using on the patient, but what you're using yourself as well for your documentation. And then you'd want to dispose by closing, folding the barrier with the dirty side inside. It's okay to dispose in their trash. And then clean your bag regularly. So our policy states every 3 months. I've seen other orgs do every month. Our bags that we use, they're non-porous, so they're not like mesh on the outside, so you could give it a good wipe down. You could use bleach if you want. It's not going to harm or corrode the bag. And I said this in the last groups, there was a study that I read leading up to this training, and it was done in a different state, but it looked at different clinical bags that were used by home health agencies, and it looked at what of the bags that were contaminated, what they contained. 80% was actually on the inner surface of the bag, and it was stuff like CRE, MRSA, C. diff, so like nasty stuff that you wouldn't want to be transmitting. So just goes to show that like we can be exposed, and you know, we don't always know if the patient's on contact until it may be too late. So that leads me to my next slide. So how do you mitigate bloodborne pathogens? You want to follow universal precautions. You want to assume that anybody's at risk for being infected. And what does that mean? You want to prevent yourself being at risk. So you always want to wash your hands thoroughly. You want to use PPE when necessary. And in addition, you want to, if you're using sharps, dispose of them, you know, timely, appropriately, never recap. You know, don't put yourself in a situation where you're going to need a employee health visit, or, you know, something that causes more care. And then lastly, we offer vaccinations. We offer Hep B upon hire, so, you know. And then just a basic review of infection prevention. So what's the number one way to reduce infection? Hand hygiene. So effective hand washing. Remember, scrub with the hand, if you're using soap and water, or the hand sanitizer. Again, we had this discussion when I started about alcohol-based hand rubs. They are appropriate as long as your hands aren't visibly soiled, and at that point you'd probably want to be wearing gloves anyways. And then PPE, so standard precautions applies to everyone. You want to wear your gloves if and when you're contacting blood and body fluids. You want to perform hand hygiene. Wear your gown if necessary, or a mask if necessary. And you want to clean reusable equipment. You want to prevent the spread. And then just lastly, some quick tips, transmission-based precautions. What are contact precautions used for? These are usually your antibiotic-resistant organisms, your C. diffs, your CREs, your VREs, your MRSAs. Droplet is used for flu if MRSA is in the respiratory stream, rubella, mumps, or pertussis, and then airbornes for TB, measles, chickenpox. And then lastly, this isn't related to our co-visits that we did in prep for DOH. However, after DOH, our next initiative that we'll be training on will be PDGM. What's PDGM? It's patient-driven groupings model. It's going to be a new, it's not a regulatory change, it's a payment structure change for Medicare, Medicaid, Medicare patients from CMS. So it'll be separated a 60-day episode. Your plan of care will still be based on a 60-day episode. However, the payment periods will be a first 30-day period and a second 30-day period. And this is going to be effective January 1. It will change from a reimbursement of therapy-driven to diagnostic-specific. So the changes, what are they? So referral source will now either be a community or institutional. Institutional being from a hospital, long-term acute care, a rehab facility, or SNF. The timing, early, means basically that patient hasn't had an episode of care within the last 60 days, so they're a fresh referral from the hospital. It has to be within 14 days. Once they've been out of the hospital after 14 days and then they're under our service, it will be a community instead of an institutional. But basically all episodes are going to be early the first time for care, and it will be late successive episodes, or if they've received care within 60 days of coming under our care. Except if they were discharged from the hospital, then it's considered institutional early. So, and then the last two, the clinical complexity, so diagnoses. So it was originally going to be slated to be, instead of 432 HERG scores, home health resource groups, it was going to be 216. There was a lot of pushback that the diagnoses weren't being captured effectively, so they changed it to 432. And reason being, there's now 12 clinical groupings, and that includes what's called MMTA, Medication Management, Teaching, and Assessment. So the reason that's important is because care is going to be grouped based on diagnoses. So that's why right now we've been trialing some things since July with our UR team in order for our liaisons and our
our referrals that we get from the community to give as much information up front as possible, because going forward, everything that we submit to Medicare on our claim has to be evidenced. It has to be a diagnosis that's specific to and justifiable to the reason we're giving home care, as well as any comorbidities or diagnoses associated. They can no longer be non-specific. Your low back pain, your muscle aches, your abnormality in gaits, it's not going to fly with Medicare in terms of their claims, so it's going to have to be specific diagnostic codes. And then lastly, OASIS, the MOO items, the grooming, the upper body and lower body dressability, the bathing, transfer, as well as risk for hospitalization is all going to be calculated into a score. And that's either going to adjust our case mix weight and make either patients grouped into a low functional impairment level, a medium, or a high. So more to come. We'll get our EMR updated in Home Care Home Base in like November. But mainly what we're looking to do is just have enough information so that way when we're given patients at referral that we're not seeking out and Marge's team isn't having to, call the doctors and the liaisons and get more information. We want to have that up front. So that's it in a nutshell. All right. And now into Gary's portion.
Good afternoon. So we're going to start by talking about HIPAA. The good news is there were no areas of risk related to HIPAA on our field visits, so you guys did a wonderful job with that. I always like to provide a reference if I can, so if you're at all interested, you can literally Google this statement starting with 45 and ending at 164 and read all the stuff that we read so we know that we're doing it right. But in a nutshell, HIPAA regulations, they're designed to protect individuals' right to privacy and confidentiality, but at the same time allow us to share things in a timely fashion, which will improve patient care, and to do so, to make sure it's secure when we do so in any format, whether it's electronic, written, or spoken. So the real key is, what's the best way to assure that we're being compliant with HIPAA and protecting our patients? Much like Ed indicated with infection control, hand washing is your primary means. Well, for HIPAA, it's the minimum necessary rule. So minimum necessary rule means only talk to people who you need to talk to and only tell them what they need to know. So who needs to know and what do they need to know? That's it, nothing extra. In addition, another good way to protect us, protect our patients, is if we suspect there's been a breach of HIPAA, say something, notify the office. We will investigate promptly. This is a big deal to protect our patients and you and our organization. So if you think you noticed something, let us know. We will investigate. We're not going to go in there angry like we did something wrong. We're literally going to look into it and see if there's something there that's founded. A key here to know is texting, the general app that comes on your phones, that SMS, it is not at all secure. So do not use text to relate protected health information to anyone, okay? Even somebody who has a right to know, you do not want to text. If there is a secure VNA approved app for texting, we will let you know. We used to have one called Cortex. Right now we don't have one. So your rule of thumb should be, I'm not going to text. So there's a lot of good about HIPAA, like we talked about. It allows us to share information very timely in order to facilitate high quality care. But there is a risk, and that risk is because of the nature of protected health information and how it's shared. There is a high potential for somebody who shouldn't know that information to get access to it. And therefore misuse it. Identity theft is rampant out there. We want to protect our patients from that. We also want to protect you, yourselves, and the VNA as a whole, which you're obviously part of. We want to let you know that there are serious legal consequences to a founded HIPAA violation. They include both civil and criminal. So literally there could be up to being imprisoned for an egregious enough offense. And in terms of civil or monetary penalties, you're looking at possibly up to $1.5 million per type of violation per year. So you can see just how devastating it could be to you or the organization, and even more importantly, your patients. So, what is protected health information? It's any information relating to a person's health status, treatment, or payment for health services that we as the agency receive and may also identify said patient or individual. It includes information about their identity and medical information. And here are some examples, and I think some of them are very obvious. You know, the patient's name, their social security number, their medical, not their medical record number, their beneficiary number, like their Medicare number or their CDPHP plan number, member ID. What you may not have known is telephone number, email address. Those can also easily be used to identify a patient, so that is considered protected health information. Believe it or not, certainly medications can be. If it's a rare enough medication for a rare enough diagnosis, you may very easily be able to identify a patient just by the meds they're taking. So again, protected health information. Their address is also protected health information. There is a tiered structure to that, so state level and above, that's not protected. New York State, United States, North America, Earth, not protected. You start getting a little bit more granular, like 35 Colvin Avenue, very much identifiable for that patient. And it's also in terms of specific dates, such as their exact birth date, admission date, discharge date, date of death. These things can identify a patient. In addition, New York State has a lot of extra regulatory requirements, which is mostly a good thing. It's protecting patients. In the case of HIPAA, there's an extra layer of confidentiality protection with HIV. So what we want you guys to know is that information regarding a person's HIV status can only be disclosed if the person who is afflicted or their legally appointed guardian signs an HIV release form. Okay? Now we have release forms here that we use when patients want their records released. There is an additional paperwork to get the HIV. We do not include that in regular records release, so it's something for you to know. If ever you encounter it, hey, I asked for a record release, but this isn't a complete record. It's because HIV status requires an extra layer of written consent. So we wanted you guys to know that. And what is it that they're trying to keep confidential? Almost anything related to HIV or AIDS. So the fact that they've had any one of these tests, for example, whether they actually have an infection or an active disease, or even if they've been exposed to the HIV virus. So all these things are protected. So how can we protect protected health information? Ed alluded to this in his part of the presentation, but always have your field bag zippered closed. There's really, at times, no avoiding having PHI on you. We know it happens. It happened to me when I was out seeing some patients here and there. So we want to make sure if we have that kind of information on us, we have a two-layered protective plan. So number one, these can be provided for you, but they can be put in an envelope. That's one layer of protection. And the second layer, if you're out in the field, would be in your bag, zippered closed. So this also applies to any PHI in the branch offices. If any of you are near the Albany or Saratoga branches and you're maybe using that as your base of operations, yes, the door locks, there's a layer of protection there, but sometimes vendors, visitors, they come in and you know, at one point here we had a contracted janitorial service. You know, we had to keep our PHI protected. So again, having an envelope with the PHI in it, even if it's on your desk, is at least some layer of protection for our patients, as opposed to just leaving it out face up, being a worst case scenario. Face down's a little bit better, but it's not that hard to flip it over. So keep in mind, These are regulations, not something we enjoy doing, and the reason they're regulations is because we're just trying to protect our patients from having their identities stolen. They have enough issues that we're already helping them with. Also, if you don't have paper version of PHI, your tablet or maybe your cell phone could be riddled with PHI if it's not protected. So remember, if you have to walk away from your tablet, which we all know happens sometimes, you need two hands, right, to help your patients. Many times, you can't always hold a tablet in one hand. So lock that tablet if you have to walk away. As soon as you click that button, it should go into lockdown, where the only way to open it back up is to put in a personal private passcode. So some other ways to protect PHI. Never discuss or answer questions about a patient's condition in the presence of that patient's family or friends unless they say it's okay. So for example, you're at a patient's home, their neighbor might be there. You may want to ask your patient, hey Janie, is it okay if your friend or your husband or whoever is here while we talk about this private information? Most of the time, I'm sure 99% of them, they're probably going to say, yeah, that's fine. And if they give you that verbal consent, you're okay. But you never know. They're vulnerable. They may say, actually, I'd rather not have them there. They just didn't know how to broach that subject, at which point you would direct the patient and assist them to ask the person to step away so you could have a private conversation. Certainly never discuss patients with staff from another agency or facility. I think that's pretty obvious how that would be a HIPAA breach. There are obviously exceptions to HIPAA, in terms of if we're sharing information for patient care, following the minimum necessary rule of who needs to know and what, then we can share that information. A good example being a referral. Our liaisons are sharing PHI back and forth with hospitals all the time. They have to as part of the referral process. Certainly don't share PHI to your family or friends. It doesn't matter how fun that story would be to tell and how innocent it is. If you can't protect the patient's identity, it's not a story worth telling. It's not worth exposing yourself or the patient to risk. My favorite, never bring your family or friends to your patient's homes. I know you all do that daily, right? And certainly, this is a big one that is pretty stereotypical. Never discuss your patients in a public environment. I'm sure you've all had the HIPAA training at least once already this year, and you see those fun videos, and you have the person on the cell phone at line at the coffee shop or on the elevator. It's very easy to overhear something you shouldn't. In the course of doing lots of HIPAA trainings, I've learned things. And actually, one story somebody told me was that an institution they worked for got cited with a HIPAA violation because two people were talking about a patient. They were very discreet, but they mentioned a diagnosis as part of describing the story, and that diagnosis was so rare that they knew everybody knew exactly who the patient was that they were discussing on that floor. So it's very easy to happen. So the last slide we're going to go over is complaints. Again, I've given you the reference if you're eager to look it up for yourself. What this regulation literally says is the home health agency should, it probably should say must, because it is a must, record in both the clinical record, which we do, and the patient's home folder, which we do, that the patient was provided with information regarding their right to lodge a complaint with our agency. Okay? In just a few moments we're going to get to how you're doing that. But that's very important that your patients know that. This educational material is in the admit packet when the start of care is performed, and it must be reviewed with that patient or the appropriate caregiver in certain circumstances. What you're educating them on, briefly, it's pretty long, but what's in there briefly that you want to let them know is we're committed to doing a prompt investigation. If they have a complaint, we're going to research it. What it doesn't say in there that I want you all to know is we're literally going to investigate if it's unfounded, because many complaints can be sort of unfounded. It's sometimes just a, hey, where's my nurse? And it turns out the nurse was 5 minutes away. Or where's my therapist? They were 10 minutes away. And we resolve that, and it doesn't become a true complaint. but we still don't want to disabuse the patients of informing us of that. But we will investigate. We also want to educate them that on that paperwork they're signing, it gives them the phone number, the office on-call phone number, as well as our hours of operation. It also informs that they can call the Department of Health or the Home Health Agency hotline if our agency does not respond to their complaint. The way that we prove that we've educated them is that they sign the Bill of Rights and the Notice of Privacy Practices. Right, we do that electronically, and we also leave a paper copy in the home as part of the admission packet. And by that, they're acknowledging that we've educated on many things, including their right to make a complaint. Of course, there's so much to educate them on that they may not remember all of it. So we always encourage that we educate the patients and caregivers to try to keep that folder handy. We know they go missing, they're misplaced, they don't know how important it is, they throw it out, they may be in an assisted living facility and somebody moved it. But we can always provide another one if needed, but we really want to encourage them to keep it there because, right, we want to go in there and see, well, what have they been educated on? What exercises have they been given? And I guarantee you the Department of Health will be looking for that folder. And I'm sure you've all heard, if you didn't document it, you didn't do it, even if you did. So my fear is the Department of Health comes in, it's not there, they're going to say we never gave it to them. Hopefully the patient will say, yeah, they gave it to me, I just don't know where it is, but still encourage them to try to keep that handy. So that completes the education we would like to do. We have the test, it's 12 questions.